public health is at the crossroads, and we must ask ourselves, what is our commitment as Alaskans, as people, as the legislature, through our administration, to public health programs? Some of the programs are models throughout the world for how to deliver public health services. I don't believe that these programs should have to compete every year to justify their existence. I don't think that we should need to demonstrate that by decreasing our support for them, that we have to then have kids who are not vaccinated and then have an epidemic 2, 3, 4 years from now to reawaken our knowledge that we can prevent these diseases through effective public policy now.
In the past, there has not really been explicit policy to guide us. In fact, I hate to say it, but a lot of the policy has followed the budget. In other words, for example, a legislature will put money in to get something done in a specific area of, say, his district. And this, in other words, the dollars have been appropriated and policy follows, which is normally just the opposite of what it normally should be. Now you're in the period where you've got to analyze these programs and say, you know, is it really worth the dollar it costs? It's nice, but are you really getting the bang for the buck? First of all, it costs more to provide the same service in a rural area than it does in an urban area. So the first thing is the realization is that there's a disproportionate inequity in the costs of providing services. Now, one of the disadvantages, obviously, living in rural areas is that you're going to give up something. And obviously what you're going to give up is, for example, you're not going to have a Mayo Clinic on your doorstep or a Providence Hospital because the population does not warrant it. So what does it mean? That means that other systems have to be set up. In other words, there has to be some type of system of health service delivery that ensures that people will get adequate services.
You yell if I hurt you, okay? Butch Fisco? The health aides are our local arm. They are the key to a Gusset public health nurse understanding how things work in the village. It would be almost impossible to do the job of public health nursing efficiently and effectively in the village without working collaboratively with the health aide.
Yeah, he's been doing okay, but he's been having slight chest problem, not a pain.
Inside?
Mm-hmm. And at the end of the day, after he's been working, he gets throbbing pains. And also, when he hit something with his, when something hit his arms or accidentally hit them, they hurt.
Does that help?
Ikaw kaka mingul ikaw.
Kingonito yu tu makhangat kinakatakalag inaknakalaming tu makhangat.
It helped you.
Can you put one finger on the spot that hurts the most?
If somebody needs medical care and it's beyond the level of the care available to them then there should be, there must be, there needs to be some type of access. And basically that we're talking about medical evacuation, we're talking about transportation. And again, we're faced with that problem. We're talking about, well, so much of Alaska doesn't have a road system, so that means, for all practical purposes, air transportation.
Well, the straps are set up for feet first.
There are a lot of factors that have to be considered in establishing a rural health policy. One of them, for example, is equity. For example, the state has invested quite heavily in hospital construction in urban areas. And I'll grant you that obviously hospitals in urban areas benefit rural residents because that's where they usually end up. But basically, the direct and immediate benefits accrue more readily to the urban residents. Well, the question is, whether does the state have the obligation to make medical care more readily available to rural residents?
The state potentially has the resources to commit to public health programs and to health promotion and disease prevention, which is what public health is all about. But the question is, what is the commitment of this state to public health and to human services? Because of the lack of funds for public health, recently the state had to stop supplying vaccine to private physicians. We know that probably the best investment of $1 in preventive health is through vaccination against childhood disease and other diseases of adults which are preventable through vaccines. And yet those programs are now somewhat threatened by our falling state revenues.
Just this past fall, I stopped providing immunizing agents to the private sector. About 30% of the money we spent on immunizing agents went to the private sector. Now, I'm not happy about it, but it was $100,000 that was saved that could be put into keeping the immunization program alive. What happens when you do something like that? Because this is always the question. Well, obviously, one of two things happens. Either you can say, well, now less people get immunized because it costs some money, of this 30% of the population, or you can say, or they will go to the health centers, they will go to the public health nurses, and that they will increase their workload. Or the third thing, and it's the third thing basically that is happening, is that it is, and I'll make no bones about it, it is a cost shift. We are shifting the cost of the vaccines to that segment of the population that can afford to pay for it.
Hepatitis B is a significant problem worldwide. When I first went to Bethel in 1972, the Center for Disease Control offered a new blood test which had been discovered a few years before, which could detect hepatitis B. So we talked with the Native Health Board and visited 2 villages and tested these 2 villages and found that the carrier rate of hepatitis in these villages was very high. In one village it was almost 10%, and the other it was about 25%, which was just as high as any place in the world. About 1980, we knew that the hepatitis B vaccine was about to be released, and that preliminary results that we're analyzing now have shown that there's a dramatic, very good response to the vaccine, especially in children. We are hoping to get, what we need to get is $1 million, roughly $1 million a year for 2 more years to catch up. We'll ask the state of Alaska to test 20,000 Alaskan natives a year, so that at the end of 3 years we've tested all 60,000 Alaskan natives, and to vaccinate those who are at the highest risk.
Walter, you were super, Walter.
I went to the governor and I said, look, this is an emergency. We now have a vaccine that we can be used, but no, the vaccine costs so much, it costs about $100 per person. And I said, we need several things. We need $250,000 supplemental, and this was in fiscal 83. I said for fiscal 84, I need $500,000, in fiscal 85, $600,000, in 86 and 87, $700,000 each. And by the end of that period, I'll be able to say, this is what it takes to maintain the ongoing program. That was done.
Well, I think that there has been a tremendous commitment among all of the agencies to tackle this disease. I think that the leadership of the Centers for Disease Control in doing the investigations and then providing the information and an initial demonstration project is fantastic, because it blazed the trail for everyone to follow and realize that there was able to be developed a program to attack the disease. I think that one potential problem with a program like this is that it is sometimes added on to all of the other programs of the public health system. And when additional positions and funds are added to tackle a major new program, that's a great step. But sometimes under the constraints of overall budget and policy, that's not possible. And so the new program must be developed, but then by necessity, other programs have to be either restricted or cut back in order to be able to tackle the new one. To see them threatened at a time when our state has potentially $3.3 billion of funds for operation of the state government is incredible.
People are not as sick as they were 10 years ago. They're having more minor type illnesses. So there's been a dramatic improvement in healthcare, and I think that the money that's been invested has paid off. And certainly there needs to be more money invested and more things done. But in general, I think there's been a real dramatic improvement. The second most important thing we can do is to improve sanitation in the villages, because I think that will really improve health care.
In the Yukon-Kuskokwim Delta region, we are faced with climatic and weather conditions and frequently soil conditions that are not favorable, and frequently traditional and conventional means of taking care of such things as sewage disposal aren't easily obtained. One of the primary considerations in breaking the chain of infection of fecal oral diseases, those diseases are spread by contamination of water and food sources, is to get human waste into the ground and have it covered in terms of confinement, keeping away from people.
Well, in traveling all over the state for the last 4 or 5 years, working in this job with the Public Health Service as a operations and maintenance troubleshooter, maintenance assistance, and training for the local operators, we see a lot of flat, water-soaked land where the ground water table is surface. And yet 5 feet, as little as 5 feet under that is permafrost, absolutely frozen solid ground. The difficulties involved in putting water sanitation facilities into rural Alaska are very great. Primary one would be environment. We're not talking about a system that evolved, that was started in a small community 100 or 150 years ago and grew, and the needs of the community were very well known from the growth and expansion. We're talking about going into places that have never had water sanitation facilities, never had a well pump, never had a water system in the houses or a sewer system in the houses. Or Tundatuliak has a washateria facility that has toilets, one each toilet in the facility with showers and washers and dryers, and they were well aware of what they were getting. They were shown examples of what was available, and they chose what they wanted with a rather full expectation of what they were going to get. And from what we've seen, and in that village, working with them, they are very proud of the facility. It is being used extensively.
What you're looking for is something right around 0 or 1. You don't really want...
Public Health Service provides a 1-year period in which major defects, I'd like to underline that major defects are taken care of by Public Health Service. And we provide a great deal of training during that 1-year period to make sure that the new operator of the facility is properly equipped, properly trained.
Okay, the smoke test is to measure the amount of soot or carbon in the gases. And of course, if we have too much soot or carbon, it'll soot up the stack and soot up the boiler.
The problems of waste disposal are very bad. Human waste is hard to get rid of. Like Kipnook, it has to be hauled out by honey bucket. and the honey bucket has to be dumped somewhere.
They dug the ground and then we make this, just the small plywood box, and make a cover. That's where most of the people pour their, dump their honey bucket.
The problem would be taken care of if we can some way get rid of the honey bucket system and then get a sewage system that, you know, like in the rural or the big cities, they have flushing toilets. I believe it would cost a lot of money to get a hold of those flushing toilets.
A lot of the problems we have are not just from drinking contaminated water, but from not having ample amounts of water to practice routine hygienic considerations. Having the ability to wash and to shower and to have clean clothes and facilities is definitely contributory to having a healthful existence and a healthier life.
I guess any area you go to in the state, rural is going to say that neither the state nor the federal government is committed to the level of service that they want. It would certainly be my view. On the other hand, their view is they don't have to be committed to the level of service that I want. The federal government, through Indian Health Service, provides a basic level of funding for the community health aid programs, some emergency medical services money, an eye care program, some dental money. This is kind of the crown jewel of our program. We are really proud of this, just having this kind of equipment and setup. We've reached the point where we can take denture clinics out to our villages. People come in on a Monday and get their teeth fitted for the denture. The lab tech comes out to the village with the dentist, sits there and bakes them, and by the end of the week they walk out with a full set of dentures in their mouth. And this is to villages that up to maybe 5 years ago weren't even sure they'd see a dentist once a year. So the dental program is just one of our favorites because it works. Basically, we go to the state for your fairly basic grants and contracts, mental health, alcohol, public health, nursing, and they fund those to some degree. Because of the high cost of living here and our need to have competitive salaries, invariably our programs cost more than any particular agency is going to give us, and that's where the borough money is helpful because it allows us to supplement what we get from outside agencies so that we have enough to offer competitive salaries to professionals and retain good people. There are a few programs that the borough funds completely on its own because they saw a need that no one else was addressing. There was no way to get money for it from anywhere else. And basically they put their money where their mouth is and said it is a need and we're going to meet it.
Okay.
The clinics have been built and designed by the North Slope Borough through its capital improvement program. They were designed by a group of us basically here in my office, most of whom are ex-nurses, and designed them based on a lot of experience in running back and forth in poorly designed clinics where they put things that should be together at opposite ends of a hallway. What we're proudest of, our telehealth room, which is a slow scan video system that has been used successfully to date in Canada between major referral hospitals and mid-level clinics. We're taking that one step further and bringing it from a hospital to a basic health clinic in a village staffed by a health aide.
I am working on explaining how this equipment works to one of our health aides, and we would like to do a transmission with you and then to have you transmit back to us.
The system is fairly simple. It looks like a TV set with a little TV camera. It enables the health aide to both communicate with a hospital here in Barrow to communicate directly with the Native Medical Center in Anchorage if there's need for a specialty consult. She can send EKGs over that machine and have them read by a cardiologist directly to tell her what the problem is. The resolution on them is sharp enough for orthopedic consults. You can read x-rays off of them. So we think it's a good system, and it's been tested in a blizzard, and we were able to communicate with Oklahoma, Canada, and Hawaii and get that kind of picture-perfect resolution, so we think it's workable.
Our whole mission is to save lives and property for anyone in the North Slope Borough area. We do that from our standpoint with aircraft, 2 helicopters and a fixed-wing aircraft. We also provide major equipment to volunteer organizations. Several of the agencies here work interface together. The Public Health Service, who has the hospital, us, we have the aircraft and a major portion of the equipment. We also, the EMS section, Emergency Medical Services, provide us trained and qualified people to go on our medevac flights. Fire department has ambulances and personnel out in the villages. Village health aides are in all the villages, and it's basically no one can really do the mission without all the rest. Plus there is a large number. The backbone of the whole thing is the volunteers, the people who take off of their regular jobs whenever they're needed to run searches or run medevacs.
Some O2 on you or some oxygen on you to help you breathe a little bit better. I'm going to be taking your blood pressure and checking your vital signs. Glenn, we're going to have to start an IV on you. Get some fluids going to help bring your blood pressure up. We'll be moving you out to the helicopter. We'll be as easy as we possibly can. It's a little cold, so we're going to cover you up.
We'll be loading feet first.
Right.
Sitting down.
The whole political arm supports us strongly, and we're continually pushing to have the best medical search and rescue services available in the state, in the nation.
Well, I think that glamour in public health is fleeting and easily forgotten. I think that many people can remember what it was like to see a child with pertussis coughing until the child turned blue and passed out from lack of oxygen, or the person who became paralyzed from polio. But part of our public health successes have been that now people don't recognize those diseases or have a memory of them, and therefore they feel that these problems have been solved. But they've not been solved. The tide has been stemmed by prevention, but the viruses exist, the bacteria exist, and an absence of continual vigilance and vaccination will inevitably result in new epidemics. And I think that's the message of public health.
One of the things that happens about public health nursing is it's very difficult to quantify, to say how much good is it done. People have perceptions about how much good it's done, and yet when it comes down to say how many illnesses did I prevent with my service, that's sort of like counting something that isn't there. And you know, certainly that's not unique to my own nursing service here. That's unique to public health all over. It's very difficult to count what you prevented.
Many of us feel that the demands for healthcare services are infinite, that there's really no restriction, and that if you remove the fiscal barriers, that there is no end to people's demand for services. And the fact is that, to be perfectly candid, unless you impose barriers between people and health services, the demand is infinite. And we've had it proven to us a million different ways.
Even though I'm trained to take care of sick people, I enjoy preventing disease more than I enjoy treating disease, and I think that should be one of our major goals as healthcare personnel.